Dear colleagues, today's video presentation focuses on congenital cystic adenomatoid malformation of the lung, which is a rare developmental anomaly of lung tissue of hematomatous nature. The malformation is characterized by abnormal proliferation of terminal bronchioles, which form multicystic or solid lesions. Prenatal identification is essential for the management of both pregnancy and the newborn. According to Stoker's classification, three main types are distinguished based on the size of the cysts. Today, we will observe a type 3 congenital cystic adenomatoid malformation of the lung, which is a solid or microcystic mass containing, in fact, smaller cysts of 5 millimeters. This type gives the lung parenchyma a homogeneous hyperechoic appearance. On ultrasound, the malformation therefore appears as a hyperechoic mass in the upper lobe of the left lung. Here we can clearly see the marked difference in echogenicity between the healthy lung and the affected one, which appears distinctly hyperechoic. The appearance is therefore that of a solid, homogeneous mass. This is because the ultrasound device is not able to visualize every microcyst, as they are particularly tiny. We then observe a significant and noticeable consequence, namely the displacement of the mediastinum and the heart toward the opposite side, so that the heart remains levocardiac, but is shifted to the right side. The presence of these signs constitute potentially negative prognostic factors that can lead to heart failure. The natural history of the malformation is variable. Progression to fetal hydrops is the greatest predictor of mortality. To quantify the risk, the cam volume ratio, or CVR, is used, which is the ratio between the volume of the adenomatoid malformation and the cranial circumference. A risk greater than 1.6 identifies fetuses at a significantly high risk of hydrops up to 75%, and this will require intensive management. The main differential diagnosis in this case is with pulmonary sequestration. That is a mass of accessory lung tissue not connected to the bronchial tree. From the point of view of echogenicity, the adenomatoid malformation, as we have seen, is hyperechoic, while pulmonary sequestration is more often homogeneous and similar to normal lung. Vascularization, on the other hand, is a fundamental characteristic because in pulmonary sequestration there is the formation of an abnormal afferent vessel that originates from the descending aorta, which we do not see in adenomatoid cystic malformation, where instead the vascularization comes from the normal pulmonary arteries and veins. So the key element is the color Doppler examination. And so, as we can see in the video, there are no afferent vessels coming from the descending aorta, whether thoracic or abdominal. Furthermore, this pathology must be differentiated from diaphragmatic hernia, pericardial or mediastinal teratoma, and intestinal duplication. It is also important to make sure that there are no associated anomalies, such as esophageal atresia, tricuspid atresia, transposition of the great vessels, interventricular defects, hydrocephalus, diaphragmatic hernia, and polydactyly, and funnel chest. These are the most frequently associated conditions. It is therefore advisable to carry out detailed obstetric management with an ultrasound examination to rule out any associated anomalies and a fetal echocardiogram to exclude congenital heart diseases, or in any case, to assess the hemodynamic repercussions that pulmonary sequestration, congenital cystic adenomatoid malformation, or diaphragmatic hernia may cause. To cause, perform an ultrasound examination every 2 or 3 weeks in order to carefully assess the amount of amniotic fluid, the appearance and spread of pericardial effusion, in other words, all the signs and indicators of heart failure, as well as thoracic effusion and pulmonary hypoplasia. Therefore, this also includes the evaluation of fetal hydrops and the remaining lung tissue in relation to the head circumference. From a prognostic point of view, in unilateral forms, the prognosis is good, but the association with hydrops or other anomalies, of course, makes the prognosis poor. Therefore, a multidisciplinary consultation with geneticists and pediatric surgeons is absolutely essential in order to ensure very close and careful postnatal follow-up and proper and effective management, including neonatal surgical intervention if necessary. Thank you for your attention.